oral ovulogens in ART. As Madam said, and as Dr. Sharma has also said, we have come back around circle. We started with oral ovulogens, and now again we are finding that they are finding a great place in the field of ART. So we need to know more and more about it. We all know that these molecules were discovered. I wonder if many of us know this, that it was basically studied for the clomiphene, for instance, was studied for the treatment of advanced breast cancer from 1964 to 74, and it was found to be effective but abandoned because of its side effect. So then afterwards, it was actually when the era of assisted reproductive technology began in 1967, that is when clomiphene found its place, and that is when we started using it. So now today, what I would like to say is, or describe, is the physiology of ovulation, a bit of it, oral ovulogens both for IUI and IVF, and the drugs and protocols thereby, and of course the results. We all know this, and I think we should not go ahead without talking about our first IVF baby, which was produced in such tragic circumstances, I would say, but of course, nevertheless recognized now. So we all know about the menstrual cycle. We know that the ovarian cycle and the menstrual cycle go hand in hand, and it is actually the hormones which are controlled by the pituitary, and that is what is giving rise to these follicular phase and luteal phase and the changes within the uterus. And based on that, we found that there were some women who had an ovulatory dysfunction. They were not producing eggs properly. And so there was a WHO scientific classification which came about in 1976 and grouped the women into three: Group 1, Group 2, Group 3. I don't have to tell you much about this. We all know, and this is how we have been practicing ever since. So the goal of ovulation induction in ART is to be able to get good fertilizable oocytes that form good embryos resulting in a pregnancy. Of course, we don't see these oocytes and we don't see these embryos in IUI, but nevertheless, the goal is the same, that we should be able to have a good egg and hence a good pregnancy rate. So then it was in 1987 that the principle of ovulation induction or stimulation was proposed by Bayards. And what was said was that there is a FSH window or an FSH gate, which is actually depending, upon which is actually depending the dominance of the follicle. And so if by some means we can either increase this window or gate by giving a higher dose of FSH, or if we increase this in terms of days, then we will get more than one dominant follicle. And that is exactly what we are doing when we are doing ovarian stimulation. We are actually increasing the FSH gate, either by giving high doses of FSH, or we are giving a slow kind of a protocol, as we do in PCOS, wherein we increase the window in number of days, and thereby we want to have more oocytes. The mode of action of all these modalities is definitely the same in some way, because it starts from the hypothalamus, it goes to the pituitary and then the ovaries, with these different drugs acting at different levels. And hence we know that now today we are talking about the oral ovulogens, so we need to understand how they are going to act on these various organs in order to have a good result. But most important thing is that we have a better understanding now of reproductive physiology. We know that there is a finite number of oocytes. We also know that each oocyte does not have the capability of giving rise to a pregnancy. This is a very important thing to understand and to recognize. Every oocyte is going to give rise to a menstrual cycle, no doubt, to periods, but it's not going to give rise to a pregnancy. This is something that we all have to know and understand. And hence, we also have come to understand that endocrine manipulation can be done throughout the menstrual cycle. And this is a very big break for us, that we can actually do anything to this cycle at any stage, whether it is follicular phase or luteal phase or anything. And stimulation can be started at any given time in a menstrual cycle. This is what we have understood from IVF. And every individual therefore behaves differently based on many factors, both intrinsic and extrinsic. Basically, there has been a complete turnaround in the reproductive physiology of the woman, and hence we have a larger window in which we can actually manipulate our treatment. So this has given rise to something called ICOS, that is individualized controlled ovarian stimulation. So we have realized that even within those three groups that we defined under WHO, there are different subtypes. For instance, a hyperresponder is going to be of different types. A hyperresponder may not be an actual hyperresponder. She may still be a poor responder within that subtype of ovulatory dysfunction type 2. Similarly, we also know that in type 3, we have a different kind of a subgroup. So therefore, these have been now individualized according to the response of the patient. So ovulation induction has now gone on to ICOS, which means that within the subgroup, we have now in 76, we had normal women and normal women or women with ovulatory dysfunction. Now we have patients with ovarian response, which is hyperresponder, poor responder, normal responders, and hyperresponder. So hence, we have changed our stance and we are now looking at the response rather than the type of patient only. Both things are going together. It's not that we have forgotten this, but in addition to that, we are also looking at the disturbances within these groups. So I would recommend this book to all of you who are practicing oral ovulogens and ovulation induction, specifically for IUI. It's a very, very good book. So these are the drugs that we all know are causing ovulation induction. And today we are going to discuss only about the oral anti-estrogens or the oral ovulogens, and we are not talking about the gonadotrophins. So these are of two varieties: anti-estrogens, clomiphene, letrozole, tamoxifen, and we also have combinations in various forms with these oral ovulogens. So anti-estrogens falling in this group are CC, letrozole, and tamoxifen, and in the combinations we have CC letrozole, CC gonadotrophins, and letrozole and gonadotrophin. So let us look at the mode of action of clomiphene. All this is repetition. I'm just skipping over all this. But it is important for us to understand that it is actually blocking the estrogen over there and also the estrogenic receptor, both in the ovary as well as in the uterus. And therefore, in the ovary, it is thereby causing an ovulation. And in the uterus, it is having both estrogenic and anti-estrogenic effect because of its effect on the estrogenic receptors. So here, it is blocking this, and hence there is a release of FSH and LH from the pituitary, giving rise to basically formation of the egg. So that is the basic difference here in clomiphene citrate. So the dynamics are that 46 to 52% of the patients ovulate with 50 milligram, 22% ovulate with 100, and 8 to 12 would need about 150 milligram per day. And the lower ovulation rates are seen in women with high BMI. We all know that. Higher free androgen index, insulin resistance, and a large ovarian volume. So basically, in a bad PCO, you will find low ovulation rate as compared to a normal PCO who is not so hyperandrogenic or hyperinsulinemic. There is therefore no reliable predictor of ovarian response to CC, and the failure to ovulate with CC within 6 months is known as clomiphene resistance. Therefore, the overall pregnancy rate also is about 55 to 73% in these patients. And despite the high ovulation rate, pregnancy rate is low because of the anti-estrogenic effect of CC on the endometrium and the cervical mucus. So we already talked about clomiphene citrate, which is basically despite ovulation. So there are two things to this. One is CC resistance, which means there is no ovulation despite giving clomiphene for six months, and a failure to conceive despite ovulation with clomiphene citrate is known as a clomiphene failure. So we have both kinds of patients. Either they won't even ovulate. If they do, they won't become pregnant. So the recommendations for CC, they go back to 2015, and we still have that continuing in the ESHRE guidelines of 2019. It is grade A recommendation, where it should be the first line treatment to induce ovulation, and the anti-estrogenic effect with CC and if it is there, then other options should be considered. The disadvantages are that although the ovulation rates may be high, the pregnancy rates are low, and there is a peripheral anti-estrogenic effect, just as we mentioned now. Again, a higher than expected incidence of miscarriage is seen in the conception cycles, and in the animal studies, direct harmful effect of high concentration of clomiphene is seen in fertilization and embryo development and on the quality of oocytes. So therefore, the other side effects which we definitely see in our clinical practice is ovarian cyst formation, abdominal discomfort, abdominal uterine bleeding, breast tenderness, and blurring of vision. So with all that, we were looking out for a new agent. So there was a need for a new agent as an alternative, or which should be oral, without high risk, and requiring minimal monitoring. And so what happened is we started looking at these AIs, or basically letrozole, as an alternative for clomiphene, because this is an aromatase inhibitor, and the proposed mechanism of action is definitely different from what we find in cases of clomiphene. Here, what is happening is, as you all know, it blocks the aromatase, and therefore the conversion to estradiol is reduced, hence giving rise to a sudden burst of estradiol from the pituitary, and also a sudden burst or surge of FSH and LH, thereby producing more of it. So it has a complex kind of an action, wherein it is on one hand blocking the formation of too much of estrogen from the testosterone, and on the other hand it is also releasing estradiol once the action is of the aromatase inhibitor is over, in such a manner that we get a good single follicle. So the advantages of this is basically what we are using as letrozole is a third generation aromatase inhibitor. These are definitely used because this is a reversible kind of an aromatase inhibitor. Its effect lasts only while it's being used. In the first generation aromatase inhibitor, the problem was that they get fixed to the tissue where they are given, and hence the effect is permanent. So we did not want any kind of a permanent effect of aromatase inhibitor. We don't want estrogen to disappear from our body. Hence this third generation was developed, which is reversible, and therefore it has a rapid clearance from the body, a very short half-life, and its action finishes in about 48 to 72 hours maximum. That is why once the last tablet of aromatase inhibitor is taken, you call the patient after 48 hours, then only you will see a follicle growing over there. Before that, because the estrogen is not released, it is inhibited, you will not find the dominant follicle forming over there. So this again from the same guideline, it says that ovulation induction in PCO patient with letrozole compared to clomiphene results in a significantly higher birth rate for letrozole treatment. In a clomiphene citrate resistant PCO population, letrozole again results in a comparable live birth rate to ovarian drilling. So both in clomiphene as well as in ovarian drilling, it is found to be better. So it sort of scores over these two things, and hence in patients of clomiphene failure with more than one cycle, where you are not getting enough ovulation or even a pregnancy rate, this is supposed to be better. So the recommendation now is that letrozole is the treatment of choice in patients of PCO, and also in patients where you have clomiphene resistance or clomiphene failure. And it is all A grade. You can see over here that it is all A grade. So when do we use letrozole then? Ovulation induction for fertility enhancement in an ovulatory patient, IVF in patients with breast cancer needing fertility preservation, IVF in patients with diminished ovarian reserve, and of course for priming in IVM, which not many people in this country are doing. So basically we will see ahead how else are we using letrozole and clomiphene now, given the fact that we are more clear about the physiology of reproduction. So just to compare the two, you can see over here that there is a difference in the mode of action of these two molecules, but the end result is the same, the formation of a follicle. In cases of AI or aromatase inhibitors, it is generally monofollicular genesis, but in clomiphene you can have more than one follicle. So now let us go on to the protocols of clomiphene first, and then we move on to letrozole. So in the clomiphene protocols, we all know about the conventional protocol, which is CD2 to CD5. We give 50 milligram minimum starting dose. Then there is a stair-step protocol. I will talk about this in a little while. Then the mild stimulation protocol and extended use protocol. This was something very, very new, which I also learned when I was making this presentation. That is, you give 3 months of clomiphene followed by 3 months of none. This is for very resistant PCOS where you cannot use anything else except a clomiphene, and you just want to go on, you just want to see whether you can form a follicle with clomiphene. So first of all, the stairs, we all know the conventional one. So we move on to the stair-step protocol, which reduces the time of ovulation in patients. So what you do is you give 50 milligrams a day from 5 to 9th day. Then you do an ultrasound on day 12 to 14. If there is no response, you increase it to 100 milligrams for another 5 days. And then you do a scan again on 16th to 18th day. This is, sorry, from the scan day till 16th to 18th day. And then you do a repeat scan after the first scan, that is on day 19 and 21. 18 दिन तक दी, 19th day पे आपने scan किया. If there is no response, you again increase it to 150 milligrams for another 5 days from the scan day till 23 to 25. And then again, you repeat a scan, you do another scan on day 26 to 28. So this is a stair-step technique wherein you increase the dose to 100 and then to 150, and you keep on doing the scans till you find that there is some kind of a follicle forming and ovulation is happening. So the time to ovulation in this protocol was 32 to 50 days less than with stair-step protocol compared with the traditional regime. The dose-dependent ovulation rate was 64% at 100 milligram and 22% in the traditional regime. So it is scoring over the traditional regime, not only number of days of to ovulation and also on the percentage of ovulation as compared to the traditional regime of giving only for 5 days. So you're going on giving it and you find that it has happened. So basically this was another trial which happened wherein you are doing a mild stimulation protocol in patients of PCO undergoing IVF. Here it is basically to see that there is better tolerance, ease of use, and comparable live birth outcomes. This was the main endpoint that they were looking at. And what did they find is that low dose clomiphene in unsuspected poor in vitro fertilization can generate more oocytes with a optimal cumulative pregnancy rate. So if you see over here, with the CC protocol, they had an implantation rate of 32.2%, a clinical pregnancy rate of 42% as against the long GnRH protocol of only 9.2%. Sorry. A miscarriage rate of 11%, which is not high, and then again a cumulative pregnancy rate. There is a drastic difference between 14% and 58% in this mild stimulation with clomiphene, and a cumulative pregnancy rate per cycle again is jumping to 51%. And the average number of embryos that were transferred was 1.39 as against 1.37 in these patients. So as you can see over here, there are all statistically significant in these patients where you were not where you were finding a poor in vitro fertilization result in these patients. Then again, this was the protocol I was telling you, this long-term use of clomiphene citrate for induction of ovulation. When you use an extended CC treatment for 3 months and a 3-month follow-up, that means as 12 cases in the first cycle, 32 cases in the second cycle, and 76 cases in the third cycle went on to having ovulation. While no ovulation was documented before treatment, a pregnancy rate was 17%. It is generally low, but it was highly significant when compared with the zero preceding treatment, which means that you give clomiphene for 3 months and then you wait again for 3 months and you keep following these patients to see whether they start ovulating themselves. And they found that there were, out of these patients, they found that 12 ovulated in the first cycle, 32 in the second cycle, and 76 in the third cycle. So basically, this is also another regime wherein you can actually do it for very resistant PCOS. Then we have the other molecule, the other SERM, which is tamoxifen. We also know that it has an anti-estrogenic effect on the hypothalamus, but an estrogenic effect on the endometrium and vagina, and its action on the cervical mucus is still controversial. It is given in a dose of 20 to 60 milligram per day for 5 days, but it has been given in doses of 80 milligrams also. And this is a paper from PGI Chandigarh led by Dr. Dhaliwal, where they compared in PCO patients and also in CC resistant patients. They compared the cycles, the daily dose of tamoxifen between 40 milligram and 80 milligram in both these cases, and they found that there was a very good ovulatory rate in cases even in the 40 milligram patients, but of course it was enhanced. The ovulatory cycles were much enhanced in the 80 milligram because the number of cases here were lesser and number of cases here were more. So they found a better ovulation rate and a better pregnancy rate when an 80 milligram dose was used. Similarly, in the CC resistant patients also, they found that it was much better when they give a slightly higher dose in these patients as compared to the lower 40 milligram dose. So yes, in these two indications, you can use tamoxifen also in these patients. And my co-speaker after this, Dr. Rashmi Sharma, is a great fan of tamoxifen. Maybe she will mention it also for a little while when she's talking about her level 1 clinics. Then we come to the most exciting part, is that the protocols of letrozole. We have the conventional protocol, then we have the single high dose protocol. We are aware of these two. 2.5 to 5 milligrams and 20 milligrams. But then we have the extended protocol. That means of 7 days followed by 10 days, a stair-step protocol like the clomiphene citrate protocol, where you observe for 7 days and then step it up again. And then you have the step-up protocol. So stair-step protocol and the step-up protocol. These are interesting protocols of letrozole, which you can use in your practice for IUI cases as well as IVF cases. So first one is, of course, a single dose day 5 dosing of aromatase inhibitor against the conventional one, which we know we are not using. We are all using the 5 days regime in our practice. And basically you find that the pregnancy rate is matching, everything is matching in this. Multiple gestation is slightly higher in the conventional one, but basically both of them relate the same, but somehow we are more happy doing the 5-day regime. And then you have the extended letrozole treatment in doing this. Now, what was done in this particular paper? They gave 7 days of, they gave clomiphene for 5 days of 5 milligram, which were included. And then they stepped up to 7 days, where another 5 milligram was given. Some of them responded. There was a clinical pregnancy and a live birth in 14 of them. Others did not respond. And then again, a 10 days further regime of 5 milligram letrozole was added. And here again, there was a response seen in 16, a clinical pregnancy in 5 of them, and a live birth rate in 3. Non-responders were 5. So ultimately, out of the 69 patients, they could find only 5 non-responders. Everyone else actually responded after giving this kind of a regime. So basically, all patients ovulated spontaneously, and none of them experienced a hyperstimulation syndrome, which is very good. And actually, it just tells us that you need to have patience with these patients, and you don't have to generally give gonadotropins in such patients. You can do very well even with letrozole. We then come to the stair-step protocol. This was compared with clomiphene in a paper wherein letrozole was given in a dose of 2.5 milligram for 5 days. An ultrasound was done after the last pill, and then letrozole was increased to 5 milligram again for 5 days. Similarly, clomiphene, we started with 50, did an ultrasound and increased to 100 milligrams after that. So although the mean time of ovulation was shorter in the letrozole group, that is 19.5 against 23 in clomiphene, the pregnancy rate was similar in both the groups. The letrozole stair-step was efficacious was as efficacious as clomiphene stair-step, because they both achieved the same ovulation and clinical pregnancy rates in both of these cases. So you can either give clomiphene or you can give letrozole, with whoever you are comfortable with. Again, you find that they compared the ovulation rate, and like I said, there was one of extended letrozole alone, that is 7 to 10 days, and the other one was that you stair-step it, that you increase it. And what did they find? That the ovulation rate in this case was little higher as compared to the extension one, and also the ovulation rate with CC was less than letrozole. So you have to be careful about, or you want to use what. The step-up protocol is entirely different. It means you start with 2.5 milligram tablet, then you give 1 tablet on day 2. On day 3, you give 2 tablets. That means you are giving 5 milligram. On day 3, you are giving 3 tablets. Okay, that means 7, and so on. So you increase it to 4 tablets by day 5, and therefore there is a prolonged suppression of estrogen and an extension of the FSH window. This is going to give rise to multifollicular development. So this is an interesting regime in case you want to do something like, you want to have 2 or 3 follicles in your patient. Then you can keep on stepping up your tablets of letrozole from 1 tablet to 2 tablets to 3 tablets and 4 tablets each day, stepping up by 1 tablet, and thereby you get many more follicles. So what is the characteristic of each of these drugs? Now you can see that these drugs are so versatile. They can actually act in so many ways by just manipulating the estrogen inside the ovary. And this is what it is saying, that clomiphene is an anti-estrogen, 50 to 100 milligram. You know this ovulation rate we have discussed, and the pregnancy rate. Similarly, tamoxifen 10 to 40 milligram, but like I said, it gives better results, nearly the same as CC. Letrozole 2.5 to 5 is the conventional one, giving a ovulation rate of 70 to 80 and a pregnancy rate again of 20 to 27%. Metformin has also been added in these drugs within this bracket of oral ovulogens, where it acts as an insulin sensitizer, but it is only of value in PCO cases. But it is not. It has to be given in those patients only, but not in the others. So now we have actually said that we are talking about hyperstimulation and hyperresponse and all this. So how can we use these oral ovulogens in IVF now? So we have come down to soft protocols, minimal stimulation protocols, and protocols for hormone-dependent cancers, and hence using these drugs or these molecules for stimulation in IVF. So the first one that is very common and convenient is the use of clomiphene, letrozole, or tamoxifen with a gonadotropin protocol. You start the tablets in whatever dose the molecule that you are choosing, you start it and give it for 5 days, do an ultrasound, and then follow it up with FSH or HMG, and then take it down up to the day of trigger, give an HCG trigger, and then you do an IUI. So this is a protocol which you have been doing, and you can do further also in your patients of IUI or even in patients of IVF. Now, in mild stimulation cycle, what are we wanting? We are wanting ideal number of follicles desired is from 2 to 7, and this kind of a protocol is now being very commonly used in the IVF clinics for donor stimulation, where you need to have only about 7 follicles, 7 oocytes, and over there you are using milder protocols so that you don't get into hyperstimulation, or you don't end up with producing too many follicles in the donor. So clomiphene is given from day 3 for 5 days, but sometimes you give it for 10 days also, as is given over here for 7 to 10 days, wherein it helps to reduce the amount of GnRH agonist that you will be requiring, because clomiphene in the first 5 days, while it is enhancing the formation of the follicle, later on it is used to suppress the LH and thereby prevent a premature LH surge. So if you extend the clomiphene, then you are using it for a dual purpose. First, for making a follicle, and then in the later part for decreasing the LH surge. Follow it up with HMG or HMG or FSH, and then you give a GnRH agonist trigger and then do an oocyte retrieval and ET. So this is basically one of the milder protocols which we are using. It is actually helpful in reducing the gonadotropin dose, definitely helps in reducing OHSS, multiple pregnancies, and dropouts also. So now again, both these protocols can be used. These protocols can be used with clomiphene or with letrozole, where you give clomiphene for 5 days or you give letrozole for 5 days, follow it up with the GnRH antagonist and gonadotropins right through. With the clomiphene or with the letrozole, you keep on giving gonadotropins till you start antagonist. We all know this, and then finally you give a trigger of GnRH agonist, and you are done with the mild stimulation. However, if you are doing IUIs, I would advise you not to give a GnRH agonist trigger, because that is actually detrimental to the endometrium that you are going to produce, and hence it is much better to give an HCG trigger in these patients, especially when you stimulate it also using clomiphene, because that is an anti-estrogenic, and then you are giving a GnRH agonist trigger, which is also detrimental to the endometrium, so your results will go down. It is much better to give HCG trigger in such patients. What about cancers now? We all know that we are dealing with a lot of patients of cancer. The conventional start of our stimulation is with aromatase inhibitor would have been that you give aromatase inhibitor only in this part of the cycle. You don't give it later on. However, in these hormone-dependent cancers where you have an ER/PR positive, where there you are giving an aromatase inhibitor right through from the day 3 till the day of trigger. You're stimulating with gonadotropins, GnRH antagonists, and then you give an agonist or an HCG trigger. But after the oocyte retrieval also, you continue with the aromatase inhibitor, because you need to keep the estrogen levels low. So this is the conventional start of a aromatase inhibitor cycle in hormone-dependent breast cancers or any other hormone-dependent cancer. But here there is something called a random start, wherein now, like I said, we've captured the physiology so well. We know everything about the physiology in the menstrual cycle, so we can manipulate. Here, we start randomly any day of the cycle. So on the initial visit, you start giving aromatase inhibitor, gonadotropin, and again you GnRH antagonist, and continue it till you get till you have to give the HCG trigger followed by AI again. Again, here, if you find that the hormones are they have out, you find that there is a follicle already developing and the estrogen levels are already high, patient has come to you at that stage. In that case, you can first give the GnRH antagonist, bring down the levels, start the aromatase also, bring down the E2 levels, and then start with gonadotropin. So random start can also be manipulated in order that you get a better control of the hormones before you get a proper collection of oocytes over there. So therefore, in all these cycles, we need to track them very well. We all know that basically we have, whether we are doing an IUI or whether we are going to do timed intercourse or even IVF, they need to be tracked very well. We all know that we are doing a baseline scan. A subsequent scan is done 8 days later in tamoxifen or clomiphene cycles. In gonadotropin cycles, it is more frequent because we have to look at the response and change the dose accordingly. And then ultimately, depending on the rate of growth, we decide when we have to give the HCG trigger. So here then, the basic difference also amongst clomiphene and the other molecules is that the growth of the follicle is larger as compared to the follicle size in gonadotropins. And this is a very old paper which was published in 1976 or 79, wherein when they started using clomiphene, they found that the follicle size was larger, and the LH surge occurs 5 to 12 days after the last day of clomiphene, and the LH kit shows a color change 48 hours before rupture. You can see over here that there is a difference in the color change and the corpus luteum formation in an unstimulated cycle as compared to a clomiphene cycle. So please remember, if you have a very large follicle also, she can still get pregnant if you have looked at the endometrium and the endometrium is matching with the size of the follicle. You find that the LH kit is also showing a change of color. This patient will definitely give a pregnancy. So this is also from the same article, wherein you find that clomiphene produces 3 kinds of responses. There may be a normal kind of a response where you have periods, subminimal kind of a response, and that is what it is. And then there is the anti-estrogenic effect. As you can see over here, the endometrium is very poor and the follicle is large. So in this case, yes, it's not going to give rise to a pregnancy. The Letovel cycle, on the other hand, is more predictable, because here initially there is a suppression of E2 and low FSH, so there is no follicle. However, when you see them on cycle day 9 or 10, as the FSH rises, the follicle number of follicles may be less, but then you will see a follicle. So and there is no anti-estrogenic effect on the endometrium in majority of the cases. In very few cases where I would say we have been giving them clomiphene earlier, now they are being given letrozole, you will find that some of them may still show an anti-estrogenic effect in the endometrium. So what about luteal support now in these patients where we are giving oral Ovulogens? Whether it is beneficial to give them luteal support, or whether we should be, even after intrauterine insemination or an IVF, should we be giving luteal support to patients whom we have stimulated with the oral Ovulogens? This is a meta-analysis, and it is of November 2013, where it was said that LPS is beneficial when gonadotropin IUIs were done, but not in CC-IUI cycles. Similar to the ART cycle, stimulation with gonadotropin directly results in a negative feedback of E2 at the hypothalamus, and therefore there is a decreased LH release. So for the luteal support, for the luteal phase, it is all a question of LH. If you have a good LH secretion in the luteal phase, progesterone will be good from the corpus luteum, and hence you don't have to support it. However, if you have disturbed the luteal LH somehow, then you are not going to find a very good endometrium. This is exactly what happens when you give a GnRH agonist trigger. LH is only there for a very short while, and hence the support is gone. So progesterone support after induction and intrauterine, again another one in 2017 from the first one. It shows that with gonadotropins, definitely there is it's favorable to give it, but not so much in the clomiphene cycles. You can see here in this in this chart here, it is on this side of the median, and over here with gonadotrophin favors it. So gonadotrophins with clomiphene or without clomiphene, you should be giving a good luteal support, but alone with clomiphene, because clomiphene gives enough of LH and progesterone, hence it may not be required. Similar thing happens with live birth rate with gonadotrophins and clomiphene, and therefore, to summarize, in level 1, RCT data demonstrates that exogenous progesterone during the luteal phase improves both clinical pregnancy and live birth rate in patients undergoing gonadotrophin IUI and IUI. However, it does not demonstrate improved outcomes with progesterone luteal support and that. Okay, so now two or three slides about the results. You can see over here that clomiphene gives a good ovulation, letrozole gives a better ovulation rate, and gonadotrophin and ovarian drilling also gives a kind of a good this thing. So if you look at the outcomes, clomiphene with IUI and clomiphene with timed intercourse, it scores very well. IUI has a definitely beneficial effect. We all know this. So therefore, IUI should be done in patients with clomiphene also. But when you look at the pregnancy rate in all the molecules together, you can see over here that HMG scores over the others. You can see that the pregnancy rate, the abortion rate, everything with letrozole and HMG is absolutely much more than clomiphene, HMG alone and letrozole alone. So therefore, better it is to give these two molecules together. However, a word of caution, you can see over here that the abortion rate is also quite high when you are using these two molecules together. This is called a network meta-analysis, where multiple molecules are compared from one from another. And in this kind of a meta-analysis, it was also found that HMG therapy has a bigger or a higher pregnancy rate as compared to bilateral laparoscopic ovarian drilling or unilateral or clomiphene therapies. This is what they compared. And so in ranking, this is HMG or FSH scores over the others as compared to oral ovulogens. This is what this chart is also telling us. So the success rate, as you can see again over here, letrozole has a very good success rate, FSH2 has a very good success rate, but the multiple pregnancy rate is 3 times that of letrozole, and CC plus metformin also gives us a good ovulation rate and pregnancy rate, and of course a live birth rate which is comparable to the others. So hence, choose your molecule properly and you will be able to do well if you know the physiology and the endocrinology of your patient. So better understanding of physiology has led to the use of oral ovulogens liberally now, and these molecules can be selectively used for improving the pregnancy rates. So thank you very much for being here with me today. Thank you so much. I will stop my slides now. Thank you so much. I think I have overshot.
Excellent, ma'am.
Thank you.
Excellent. Ma'am, just 2 queries before we go on for the expert advice. Low dose of CC, and what dose was low dose?
50.
50, and you continue giving that?
Yeah, 50.
And what about the 3-month schedule?
That is 100.
100 for 3 months.
100.
Continuously
yes.
we are
Yes,
giving.
continuously 100. This is what I found for the first time. I'd never read it before.
Okay.
But it seems to be doing well in some patients. So we should try it.
Good insight. So,
Thank
ma'am,
you.
Dr. Sharda Jain, ma'am, your comments, ma'am.
I think Dr. Sonia Malik, you have opened a Pandora box, and I think each item has to be by you has
Look
to be
at-
detailed. You know,
Yes.
now we got an overview, but I think you have to take 2-3 sessions. One of IUI and one of IVF. That is going to make a difference, because I think for most of us, it was very new. It was very new. So thank you for updating on the behalf of everybody. I can say that
Thank you.
I was thrilled.
Thank you, ma'am. Thank you so much. For me also, it was very new. For me also, it was very new, madam. I learned a lot. Thank you very much, ma'am.
Dr. Sharma, your
Sharma?
comments?
Thank you, ma'am. Excellent lecture as usual. Madam, do you have any experience of giving depot agonists?
Agonist?
When the random protocol, you mentioned for the trigger, you can give SCG, you can give agonist, and you can also give a depot agonist.
I haven't used it ever. But as such, I am very wary of using agonists as triggers. Only in cases of donors, we sometimes use it, but otherwise, I don't like to use it.
I was just wondering whether, because the depot, if we give it, will we be able to have a mature oocytes or not? I'm not sure.
With the depot, I don't know. I mean, why do we require to give a depot? Why not a small dose?
That's what I'm saying. No, because in malignancy, you are starting the random. So you want the patient to be suppressed. Possibly because of that reason, they are giving.
All of you mute yourself. All of you mute yourself.
Yeah, you can't hear anything.
I mean, actually, there is a lot of. There was a lot.
Yeah. Can you? Yeah. What I'm saying is in the random protocol, basically it is for the malignancy patients only. So you want the estrogen firstly to rise less, and you want it to come back to down early. So for that matter, possibly they were giving depot agonists as a trigger, and so that they don't have to continue with the cetrorelix or something later on, or letrozole to keep the estrogen level. But I do not know the physiology behind using a depot agonist for a trigger, as you mentioned in your random protocol. Can't hear you.
I muted him, ma'am. I muted him.
What you're saying is logically correct, Dr. Brigadier Sharma. The only thing is that, because why I'm saying you're logically correct is because in these patients, it's actually going to be a frozen cycle, isn't it? We are not going to transfer. So it doesn't have any effect on the endometrium. Once you've retrieved the oocytes, it's all right. After that, you suppress it with GnRH agonist for a long time, or you suppress it only for a short time. It doesn't really matter. But I think giving letrozole would be much better, or basically that is actually used also for breast cancer as a molecule. We are using it. So why give GnRH agonist as a depot preparation? I don't see any beneficial effect of using it as a molecule. I don't know. I may be wrong. I haven't read it, and I've never used it.
Because it was mentioned in your slides, I was wondering.
Yeah.
What could be the reason?
So Dr. Meenakshi, go ahead.
No, I like Dr. Jain was saying, I think there's a lot of food for thought for us today. So there's a lot we've learned, and I think it needs time to assimilate it, understand it, and probably have revisions, because I mean, it was really a new world which Dr. Sonia Malik has opened up to us today. So, giving extended protocols and mixing them up, as well as, understanding where exactly we require luteal support and not. I think not only was this informative to people who are practicing IVF, but even those of us who are not practicing IVF, but doing IUIs or fertility management. I think, like Madam said clearly, that there's a lot to learn. And thank you for, at least starting the process.
Thank you. Thank you so
much.
But
I think this luteal phase support, we know for very long that if you're using a CC and latros, then you don't require any luteal phase support. Only when you use combined with gonadotropins, luteal phase support is required.
Dr. Renu Misra, ma'am, are you there?
She's there.
Yes.
She's very much here.
Thank you. Sonia ji, after your talk, I don't think anything is left to add. It is so exhaustive. You have to take time.
I think I stepped up. I overshot the time also.
No, that's okay.
Rashmi is waiting.
So, just to reiterate, like what Dr. Sharda Jain ma'am was saying about luteal phase support, that we don't need to give luteal phase support, particularly for ovulation induction and IUI cycles with oral Ovulogens, and particularly with clomiphene. Because this I read a few years ago that with clomiphene, the LH pulses are increased. In fact, with clomiphene, the progesterone level is higher than even natural. But then forget about ovulation induction or the oral Ovulogens. There are people who are giving luteal phase support in natural cycles also. You see prescription nowadays where people have seen a infertility or a gynecologist, not an infertility specialist, and they are told that every month in the second half of the cycle, you take testosterone or some progesterone. So much overuse of progesterone in natural cycles, but it is not required. But there's so much more, like.
Ma'am, I'll ask one question. Many times we get an ultrasound in early pregnancy, and they say that the corpus luteum has gone. So what will be your opinion in such cases to supplement with progesterone?
I was going to say this when everyone was saying that it should, because the two meta-analyses or the Cochrane reviews are definitely saying that it should not be supplemented with
Okay, yeah.
progesterone in CC cycles. But then again, these have been also refuted, and there are papers which are saying that it is needed, because all the corpus lutein or all the eggs that are produced with clomiphene and letrozole are not up to the mark. You may get a pregnancy, but there may be deficiency of progesterone. And since you are, and even your LH support, LH may not be the one which is required. You may have a problem over there also. Who knows? We haven't seen it, no. So that is the premise under which, as Renu was saying just now, people are also giving it for natural cycles, and they are giving it for clomiphene cycles. Actually, to gather evidence in any human disease is very difficult. It is very difficult to find that particular cohort where you have to give this and where you have to give this. Because when you go into these papers, you will always find that there is a problem in selecting those patients, and then you are fine. The end result or the point, the last end point of every study depends on the type of cohort that you have selected. And you may have made a mistake over there, and therefore your results are biased. So that is my way of looking at it. Every person for himself, every woman for herself. You look at your patient in front of you and decide what you have to do.
That is true, but then you yourself said in the very beginning that every egg is not going to get a pregnancy.
Absolutely, that's what it is. Yeah.
So then, I mean, can we justify giving drugs just thinking that this cycle may not have adequate response or adequate luteal phase support?
Exactly why we have these guidelines and why we are looking at evidence, because we don't know really. And just as Dr. Sharma said now, which patients would require a depot and which patients would require a smaller dose of GnRH agonist, we don't know. There may be people who will be requiring it, and there may be people who don't. I am a strong proponent of progesterone, so I have different views on it. I can't, therefore I can't say anything. I mean, I keep giving that.
I think AI. So anyway. Here, the AI will tell you, in few years, AI will tell you which one to give and which one.
Probably yes.
So, Madam, as always, an extensive lecture, but I have some questions to ask you, and they're very basic ones. That's for the people.
Please.
And since letrozole has come, everyone has been talking about using this letrozole. Now, what are the patients where we can give clomiphene? Because now we know that PCOS 100% we are giving letrozole, but now if it's a normal responder, everyone is giving letrozole. Are there certain subset where we can give clomiphene as a first choice?
The answer to this is that you don't know who are the patients who are letrozole resistant. There are patients who are resistant to letrozole. Not everybody is going to ovulate with letrozole. So therefore, even if you give clomiphene still as the first line treatment, it is still all right. You are going to have a 70% success rate even in that. So it's not very different in letrozole and clomiphene, is there? So again, my first choice is always clomiphene. I'll tell you why. Because with clomiphene, you can actually, if you want to, suppose you have a repeated IUI failures, you are going to do another clomiphene cycle in a patient. You need to know what is the level of estrogen where the follicle is going to rupture or where you are going to give a trigger. You will do it. It may be sounding invasive and doing too many tests, but here you want to decide whether you are doing the right thing or not, because she's had failures. So if you have a good level of about 150, 175, 200, you will give a trigger. In letrozole, what will happen is the E2 level is 90, and you're saying, oh, follicle to 20 ka ho gaya, but E2 abhi 20, abhi 90 hai, abhi ruk jao. It will go further. At 90, it will rupture. There is no correlation between the E2 levels and the size of the follicle in letrozole cycle. So how are you going to decide when to give the trigger? You don't know. That is my biggest problem with letrozole, and I don't have any answer to this. I've asked so many people, maybe Brigadier Sharma can tell me. So my question is how to decide. Hence, I always prefer clomiphene, Jyoti. And if I don't succeed with clomiphene, then I start with letrozole. That is what I do, especially in difficult cases. Especially in these patients where you don't know what is happening.
So in case we have a normal AFC count, we have a normal AMH, we can go ahead and choose
Yes, of course.
CC as the first choice, and Letros we can reserve for mainly the PCOS or the ones that is there. And second question, madam, what is the role of GnRH agonist? Which are the cases where you give GnRH agonist for an IUI cycle?
I don't generally do that. I'm totally against it. Unless you want to give see Jyoti, if it is a PCO and there you have formed 4 follicles I would say, and you're wanting to do an IUI and you want that this patient shouldn't conceive or go into hyperstim, both things. Because if you're going to give a GnRH agonist, you have to give a very strong luteal support. Only then she will conceive, right? So if you think, oh, मेरे को डर लग रहा है अब ये ट्रिपलेट ना हो जाए, अब इसके 4 ना हो जाए, because I formed 4 follicles, so I will give her a slightly lesser, which is being a devil to the patient. But nevertheless, you're playing it safe. So in those patients, I don't mind giving a GnRH agonist trigger. But in others, definitely HCG trigger.
Ma'am, I meant not just the trigger, but like we have a premature rupture of follicles in the last cycle.
Yes.
So in this cycle and antag, would that be helpful to prevent? So those particular indications where we can give an antag.
Yeah. Of course, if you have to give an antag, yes, you can, because basically, if you're scared that the premature LH surge is going to happen, especially if you're dealing with PCOS, it can happen. And mind you, it will happen very early in the cycle, even on day 5 of stimulation, day 6 of small sizes, because the moment the estrogen rises in these patients, she'll throw a surge. So you have to start it early on day 5 rather than day 6 or 7, where you're looking at a 14 millimeter follicle and an endometrium also.
Dr. Jyoti, I feel, I think I will love to have your comment. IUI has to be kept very simple.
Yes.
And we should definitely mind as for the cost is concerned, because the yield is only 10 to 12% unless you're using an HMG. Exactly. We must keep it absolutely simple as far as the IUI is concerned, and not rush for antag and things like that in IUI cycles.
And can I make a comment, ma'am?
Yeah, Dr. Rashmi, welcome.
Yeah. So, ma'am, I was just wondering, with the premature LH surge, premature rupture of the follicle, and the static growth of the follicle, which suggests premature LH surge. So we know clomiphene and tamoxifen both are selective estrogen receptor modulators, and they are blocking the estrogen receptors at hypothalamus and pituitary, and that's how they are working as an ovulation induction agent. And the same estrogen receptors are needed for the LH surge. So if, let's say, clomiphene is blocking the estrogen receptors in the hypothalamus and pituitary, it will also block the premature LH surge. As has been seen in lots of egg donor women, clomiphene we are using for preventing premature LH surge in IVFs. So I was just wondering that maybe tamoxifen, which is sister of clomiphene, I have been using a lot in my practice, as madam said clearly, particularly to prevent premature LH surge. So in a patient in whom in the previous cycle, the follicle had ruptured at 12 millimeter or 14 millimeter, or there was a static growth, so, instead of going to the antagonist in the next cycle, what I do in my practice is letrozole and then add a little bit of tamoxifen, which is 20 mg till the time of trigger. So that tamoxifen is blocking the hypothalamic and pituitary receptors, working exactly like clomiphene, but not affecting the endometrium, not harming the IUI result also. And somehow it works, because there is definitely a physiological basis for that. There are no studies on it, but yeah, this is something which we can definitely do a study.
Totally new concept. Yeah.
Because
I do that a lot.
With clomiphene, if you have to block the LH receptors, then later on, or to prevent a surge, you have to give it for a longer time. You have to give it, and that will definitely have an effect on the endometrium. Here you are basically, having a dual kind of action.
Yes.
In tamoxifen. I told you she's a master on
endometrium as well, So, and
I think we're going to stop this discussion now. We'll take up a second presentation.
Yes, definitely. Okay, thank you very much. Thank you.
Thank you very much again, Dr. Sonia Malik. I think you have to come back here and revise our things.
Thank you, ma'am. Thank you anytime. Thank you.
Ma'am, you have opened a new chapter at all. Totally.
Thank you so much. Thank you.
Dr. Rashmi is a graduate from BHU, and she is a recipient of Hall of Fame Best IVF Specialist in India in North from Economic Times, and doing lots and lots of good work, and very good word from Dr. Sonia Malik. So let's hear from Dr. Rashmi how to set up a level 1 clinic.
Level 1. Thank you so much, madam. And this is especially, I'm really honored in front of my mentor, Dr. Sonia Malik. Whatever I've learned from her. And thank you so much, Delhi Gynae Forum, for giving me this wonderful opportunity. So I'll just share the screen.
I just wish to ask you,
Yes,
there was a stage when hardly people applied for a level 1 clinics, and so much so the Director General of Health Services asked me to, to put it in Delhi Gynecologist Forum that why people are not applying. So I'm not sure how many people have applied. So you must give some insight there also, please.
Yes, madam. Yes. So, yeah,
please help.